Well, there are 48 people now on the Zoom meeting, which I think is a good enough number to start with. So I'm going to ask Fliss if you can start sharing the slide deck. My name is Simon Stockley. I'm a GP in Eaglescliffe, and I'm also the Royal College of GPs senior lead for COVID disease and pandemics. So you can imagine I've been a little bit busy of late. And I'd like to present to you the Tees Valley COVID-19 virtual ward. Next slide. The aim of the webinar is to give you some view about what the virtual wards are, why the Tees Valley is really keen to be part of the pilot program, to describe how we're going to do this and what will happen with patients and GPs, and the importance of evaluating what we do, not just for the Tees Valley, but actually for national COVID planning. And then there'll be a Q&A session where you can tell us what you need to know and what we've explained well and what you want answers to. And the panel will then try our very best to answer your questions. Next slide. So we have 4 presenters, Dr. Sathya Murthy, Dr. Janet Walker, Fiona Adamson, and Tony Roberts, who are respectively the lead respiratory consultant for James Cook, the medical director of our wonderful Tees Valley CCG, the CEO of the Hartlepool and Stockton GP Federation, and Tony is a director for clinical effectiveness at James Cook and leads for the patient safety with the Academic Health Science Network. We're also going to be supported in the Q&A by myself and Claire Adams, who is a respiratory nurse lead. Next slide. I'm now going to hand over to Dr. Sathya Murthy, who will take us through the rationale. You need to come off mute.
Mute. No voice mistake. So my name is Dr. Sathya Murthy. I'm the clinical director at James Cook Hospital. Thanks, Simon, for inviting me to present this. So my job is to give an overview of COVID-19 and why I think it's an exciting project that we're all involved in, and I think this will transform care that we are giving to our patients. So COVID-19 as a disease has presented many challenges. To give a kind of an insight into what's happening into secondary care, we had about 58 ward changes in our hospital. And a lot of clinicians had changed their kind of a job plans and adapted quite quickly to learn about this disease quite quickly, which was changing almost on a daily basis, I would say. To give a kind of an idea of what the management has been so far. So initially we thought there was no kind of a treatment that we could offer for these patients apart from invasive mechanical ventilation and critical care. And after a few days to weeks, we found out that actually mechanical ventilation could be harmful for patients, and then non-invasive ventilation might be better for patients presenting with hypoxia. We also found that it doesn't present like the usual kind of an ARDS picture. People will be very hypoxic, but they are not as breathless as we normally see patients. I'll come to that point later on. We also found out later that this disease gives rise to more thrombotic events in people, and they presented with very high D-dimer, and we need to rule out pulmonary embolism in these patients. So as you know, this is caused by a novel coronavirus. People present with unusual ways, especially with loss of smell and taste. They can present with usual viral symptoms like extreme fatigue, myalgia, and breathlessness. So this virus is thought to enter the nose and the lungs through the acetylcholine receptors, and then cause inflammation in the lungs. Uh, the cytokine response, which is the main reason for them to have the inflammation in the lungs, usually starts off in the day 6 to 10 days. So later on with the recovery trial, we found that treatment with dexamethasone and oxygen early in the disease can affect the outcomes, which I'll come back to in the third slide. Next slide, please. So what's the aim of this virtual ward is to identify people who show signs of early deterioration in the community and to get them to an appropriate place to initiate treatment to have a better outcome. The next slide, please. So we are, as I alluded to you before, this disease causes significant hypoxia, but we don't see people as breathless as you would normally see, for example, who present in an asthmatic or a COPD exacerbation. There's a number of reasons which has been given for this, from oxygen dissociation curves to the chemoreceptors in the medulla not being receptive to the hypoxia, and hence the people don't have the usual kind of a breathlessness that they identify with acute respiratory failure. So a lot of secondary care hospitals, especially in London, Manchester, had piloted the virtual ward with monitoring of oxygen saturations in the community by discharging patients earlier. And they found that they can look after patients safely at home. And it also gives the opportunity for them to be identified earlier if they deteriorate and bring them back to hospital for treatment. So as you would probably be aware of, the recovery trial, which is a randomized evaluation of COVID treatment, it also changed significantly. There's been at least 6 protocol changes in the last 3 months in the recovery trial with newer treatments, which had been trialed out, including hydroxychloroquine, azithromycin, and lately they are also trialing out plasma treatment as well. So dexamethasone, 6 milligrams for 10 days, did make a difference, especially in people who required oxygen and also who required invasive mechanical ventilation. So it improved the outcomes in those category of people, but it did not improve the outcomes in patients who did not require oxygen. So it's important that we identify people earlier when they become hypoxic, so they can be brought to hospital. And if they fit the criteria, then they can be initiated on steroids. One of the questions that might come up your mind is why not just give steroids to everybody? But we have evidence in the previous coronavirus infections that if you give steroids, the viral clearance has been delayed in those viruses before, like MERS and SARS in the previous years. So that's the reason why it's not advocated to start steroids in patients, and the outcomes in people who don't require oxygen as well has been poor. Next slide, please. So there's definite evidence at the moment that low-dose dexamethasone improves the mortality at 28 days, especially in people who require invasive mechanical ventilation, as well as who require oxygen. And antiviral remdesivir also shortens the duration of the disease, but it doesn't have any effect on the mortality. So in rationale for the virtual ward is, yes, most of the people do recover themselves, but it's important for us to monitor these patients in the community quite safely so far from the data, and also identifying patients earlier so they could be brought to the appropriate place and a treatment initiated. We are hoping that we can do this and learn from this. And we are glad that we have been selected as one of the 3 pilot sites in the nation, which we should be very proud of. So we would be needing to learn quickly through this phase and also disseminating our results to the nationwide so other sites also can implement this. That's all I have to say from the rational point of view. So I will hand it over to Janet Walker in the next slide. Unless somebody has got burning questions.
Janet's going to need to come off mute.
I'm off mute now. Thank you very much, Simon. Thank you very much for that introduction, Sathi. I'm Janet Walker. I'm a GP locally in Eston in Middlesbrough, and I'm Medical Director of the CCG, and it's great to be talking to you all this evening. Why Tees Valley? Well, the Tees Valley, it's a big population, 700,000 patients with significant areas of deprivation. You know it because you work amongst it on a daily basis. We know that we've got very high rates of smoking, we've got high rates of obesity, and yes, we all care passionately about our population. So it's for those very reasons that when we saw the cases of COVID rising locally in the Tees Valley, yes, you've got to ask yourself, what could you do that could make a difference to improve the outcome for those patients? And what can you do in GP land out in the community that could influence that earlier identification of those patients before they have chance to deteriorate such that their position isn't recoverable? So that's where the concept was born, that it seemed a very good idea, eminently sensible, monitoring those patients with pulse oximetry in their own home so that you can detect those early changes by working with them in that 2-week period that we know is where that deterioration is likely to occur. So the approach was that yes, patients will be admitted to a ward where they will be supported by nursing teams to be able to respond to their symptoms and act upon any change in their pulse oximetry by the use of a digital app. Now, understandably, everyone has not got access or the ability to use a digital app. So yes, whilst that is a main driver of it for those that can, there are provisions made such that with anyone who isn't digitally enabled can have a paper-based system or even have a ready-made translated system that will be able to be running alongside those that are able to use the app. If we can have the next slide, please. Thank you. Please. Understandably, yes, we are all part of the Tees Valley team, and we know that for this to have success for that big population, it's how we can have a lot of people working collaboratively together, which, yes, as we all know, is a mixed blessing and a curse at the same time, with all sorts of people with vested interests, but it is a team. And I'm delighted to say that, yes, the federations are helping us present this evening with an alliance of the federations. Must note, Simon, sorry, apologies from the Elm team. They are actually having their board meeting this evening, so they aren't able to join us on the call, but obviously we'll all be watching frantically afterwards. But so it's fab that we've got the alliance of the federations. We're working very closely with NHS England, NHS Digital and NHS X, working with the Imperial College London through the research element and the Academic Health Science Network as well. Because yes, it's great that we've got this opportunity in the Tees Valley to learn how we can do it. Yes, we've made pitfalls, we've hit the pitfalls, we've made the mistakes along the way, but it's how we can learn from those, share those with the national teams that then will be potentially looking for the rollout and scale up on a national basis. Obviously, yes, it's great that we've got Sathi here with us today from James Cook Hospital, and yes, we will be expanding into the other phases into the other local hospitals at North Tees and Darlington Memorial Hospital as well. If we can have the next slide, thanks, Bliss. Thank you. Patient selection wise, yes, this looked very different just a short time ago, but because of the number of cases falling from COVID, for us to actually gather enough patient data to be able to inform any national service delivery of an approach for pulse oximetry for patients in the community, we had to widen the criteria to basically everybody that may potentially have COVID or be proven to be COVID positive in the adult age bracket. So they've got to live in Tees Valley to be selected, you've got to be aged 18 years or over, and you've either got to have a positive swab or and in the acute phase of illness, or you've got to be symptomatic with suspected COVID, and either you may have had a swab taken, but the result may not be available as yet. As we've said, children are excluded, and patients with chronic hypoxia just aren't suitable for the ward because obviously it makes the parameters very, very different. And understandably, patients with an emergency healthcare plan in place where a treatment escalation to admission wouldn't be appropriate, it obviously wouldn't be in their best interest to be entered into the pilot phase. all the phases of the project, they are the same selection criteria. Thanks, Felicity. If we can have the next slide. So I know this is very busy, and I hope it'll be easier for people to see actually when we circulate slide packs later. The referral sources into the virtual ward are from initially going to be just based around the hot clinic when we start and to trial and test the process to make sure that yes, we've got things ironed out, we've got our systems and processes in place. So initially, I know there's lots of referral points on the slide, but initially in the first phase, it will just be taking patients that already are in the hot clinic, because it makes it just be much easier to try it and test it. After that very initial phase, the referral sources will be widened and will include referral from A&E, from hospital discharge, from patients that have had a shorter or a longer, but are still in the acute phase of their illness and require some enhanced monitoring. It'll be patients that are referred in from GPs. There'll be patients coming from care home settings. There'll be patients referred in from 111, and from the test and trace. It's the national programme. Understandably, all those patients have to be, as we said, aged 18 years or over, and have either symptomatics of COVID or be proven swab positive. They will be admitted to the ward during office hours, Monday to Sunday. They will not be admitted overnight, although that referral process would enable them, their need for admission the following day to be flagged through, but it will be operating the admission from an admission perspective during the daytime hours, and it will be a 7-day service. I am delighted to say that 7-day remote monitoring service will be provided by an alliance of the federations across the Tees Valley, which I think is a real plus. Understandably, these patients, yes, they are still in our care, in primary care across the Tees Valley. What the service provides for them is that enhanced monitoring. So yes, if they had an ingrowing toenail, that would still come back to the GP, but their enhanced monitoring, that is what the virtual ward approach will be doing for that 7-day service. If they are identified during that 7-day service as needing additional help and support, potentially a face-to-face consultation where that is needed, that could be accommodated in the hot clinics, or it would come back potentially to the GP that is still providing that ongoing care and has a responsibility for the home visiting in hours or out of hours. It would be in the out of hours period as well. Understandably, if that patient deteriorates really rapidly and a 909 response is required, then that would be facilitated, and that would be another interdependency from patients from the ward. Can I have the next slide, please? Thank you, that's lovely. Now, again, very busy slide, lots of information in this slide, and I suspect some of you will already have seen it already. The box of most interest for our quick run through this evening is the COVID remote monitoring virtual ward, yellow and green, larger slide. Now that identifies who will be having on the ward, which patients are going to be suitable. Understandably, those patients who are significantly unwell as a result of COVID will not be being admitted to the ward. If they are already in the severe category, they will be taken to other routes and understandably have a medical referral and admission as appropriate. It identifies those patients that, yes, are in the categories of mild or moderate that would potentially be suitable for monitoring on that virtual ward. Obviously, yes, that it involves a clinical assessment to make sure that the right patients are coming through. When the patients are admitted to the ward, it will be a member of our nursing team that will be doing that to make sure that there is that clinical oversight of those patients. There will be some administrative functions, but yes, we will use a skill mix to make sure that that works well. But I don't mean to take your slides, Fiona, sorry, I will stop there. But it's identifying those patients and helping to get those patients to the right place. And that's just a pictorial representation I think people will find quite useful. And as I say, many of you will have seen already. If we can have the next slide, please. Thank you. Understandably, yes, this has snowballed from what seemed like a clinically very good sound idea at first into something that, yes, really obviously has become quite on the large side. And so there is a big support team around us, as we've mentioned. And yes, there's governance processes to make sure that we have done it right, that we have got our risk issues, that we have got our project plans, that we are aiming to progress at pace. As you will all know very, very well, things in COVID have taught us, by gum, you can move an awful lot more quickly than you would ever thought possible and might ever have wanted to do. And yes, that gives its challenges, as we've said. But understandably, there has to be that governance support around everything that we do to make sure that we are doing things safely and for the best interests of our patients, with all the required processes and documentation in place. understandably, there's governance at a CCG level with an oversight approach. And yes, understandably, as we move into mobilisation, that governance need and requirement extends to our federation colleagues. And yes, I know Fiona will pick up some of the elements that are relevant to this during the what next and the how it happens process. Understandably, throughout it all, this is so important that we get the evaluation right, that we get the useful data that NHS England requires to be able to prove which patients benefit most, which patients don't benefit most. And also a really important part of that is the feedback as to how it is from a patient experience point of view, from a clinician experience point of view, and how logistically the service manages to run and needs to run from a cost effectiveness point of view and a clinical effectiveness point of view. And thank you. I think that's the end of my slides. Thank you, Fliss. And I'll now pass on to Fiona.
Thank you, Janet. Yes, I was just panicking that you'd said what I was going to say, but they always say you need to repeat it, don't they? I'm Fiona Adamson. I'm the Chief Executive of Hartlepool and Stockton Health. I'm going to take you through a whistle-stop tour of the detail. I think before I do that, I just want to say two things. The first is, if you're sitting out there at home and thinking, I'm going to work in one of these clinics and nobody's told me what I'm supposed to do, then that information and training will be coming your way over the next few days. That this is moving at a really rapid pace and we want to make sure we train you on the right things. And the second thing is that this is a true pilot. So what we tell you today may well change along the way as we learn and as we adapt. So that's the first bit. Janet has mentioned two phases. The first one being the patients that present via the HOP clinics and the COVID clinics that we all have across Darlington, across Middlesbrough, Redcar, Hartlepool and Stockton. That is probably a phase that lasts about a week. And it will probably start on the 27th of July, but please don't hold us to that. That will give us a chance to test our systems, and then we move into phase 2, which is clearly far more complex and has the various referral sources, including track and trace, including ED, including urgent care, people who've been in hospital and come out, or 111. So the second phase is very ambitious. We are still working on the pathways for phase 2. For those of you who are aware of the integrated SPA that exists in some of our localities, that might be one way. But what we want to do is make sure this works for secondary care colleagues as well as the ward itself. So if I could move on, Fliss, please. Thank you. So ward admission. So it's probably worth stressing that this is still a virtual ward admission. 3 organisations working together, so it's really important that we use one process, that we're all doing the same thing with our patients, no matter who's monitoring the ward on any given day. And at the moment, that will probably be the Hartlepool and Stockton Health team during the week and the Elm team at weekends, with the Darlington team in the evening, should we get to the point of needing that. But of course, all these things may change as we go along. The patients won't know the difference. So when they are admitted, we will use a template to make sure we collect the same data. And you can see their demographics, risk factors, as we know, are particularly important. We will use System 1, and I'll come on to that in a couple of minutes. I apologise to those of you who are out there on EMIS and are already groaning. All I can say is that Simon is one of those people groaning, so he always makes sure that it works properly for EMIS practices. So what will we actually do? Well, we will give the patient an oximeter to use at home. We will give them access to an app, which will be free of charge. Our nurses, certainly in the first phase where people are coming from the COVID clinic and beyond that in the weeks afterwards, we'll try and give them a demo just so that they can see what it is they'll be expected to do at home. And then we'll start the data collection. So if I move on to the next slide, please, Fliss. This is just an example of a leaflet. I have to say, many of the people that I've met in our locality would probably look at that and be terrified. So I'm sure one of the things our pilot will do is find ways to translate the information so that people can actually understand what they're expected to do. But there will be really detailed guidance as patients are on the ward. So the risk of sounding like a government press conference. Next slide, please, Fliss. So this is the app. The app is absolutely fantastic, I have to say. I've been so impressed with it. Firstly, it's really good for patients. So it's simple, it's intuitive, it's already been tested on other conditions. You can vaguely see on the screen there that it's RAG rated. So patients will know if they are in a danger zone, if you like. They'll know if they're okay for the moment, and they'll know if they need to seek some other sort of help. So there are prompts, there are alerts, and the other excellent thing about it is that actually the ward staff can use it too. So it creates a dashboard so that the nurses in our clinics can see, who do I need to check up on? Who do I need to chase who hasn't done it? Who do I need to make sure has called 999, etc. I can't say it's perfect, and I'm not allowed to say that, because locally we are working on, at ICS level, I say we, I mean Claire and colleagues, on a local app that would actually connect to our clinical systems too. So we're hopeful we might be able to use that, but we can't promise yet. So if we move on. Okay, so once someone is on the ward, this will be a nurse delivered service, clinician supervised, so with a GP available for advice. The data will be shared. Each federation will use the same process. Patients will be encouraged to submit twice a day. That will be the benchmark. And if you enter something into the app that's outside the normal range, it will tell you what to do next. I've mentioned the red and the 999. I think the particularly interesting piece in terms of what we're looking at locally is those people in the amber, and it will be possible and quite likely that the nurse will contact those patients and they will be asked to come in for some form of face-to-face assessment. And Janet and the medical directors of the federations will, I'm sure, get together and work out what that face-to-face assessment should contain. The nursing team are there to help. They'll be there to encourage, they'll be there to help. There'll be a helpline that patients can contact if they're struggling with the technology. I'm sure we all do that sometimes. So, and there'll be a phone number that will be the same to patients no matter what day they contact. So next slide. Patient support. So our nurses are going to be so important to this process. They're going to get people on board. They're going to make sure it works. There may be occasions when we need to deliver an oximeter to a patient's home, but we're hopeful that by having as many as possible across the locality, whether that's in the hospital, in the COVID clinics, etc., that's actually a small part of what we need to do with this. I just wanted to highlight for a second the link to social prescribing that I've mentioned. Some people will be asked to isolate. They may not have family, they may not know how to get any food. And we've been really good across the Tees Valley at getting cracking with social prescribing, and they could be really important. Sorry, we just had a 6-year-old join the presentation there. Yeah. The nurses will also ensure that patients act on the abnormal results. So next slide, please, Bliss. Janet mentioned this topic. It was something that was close to all of our hearts. We know the risk factors around ethnic minority groups. We know the risk factors around some of our older population. And what we didn't want was to create something that didn't work for them. So we will be innovative. We will find ways to include those people. And actually the app will allow us to contact the patients, take their reading numbers from them and input actually in the ward so that everybody will be on the dashboard, which will also be important when I mention quickly the record sharing. So next slide, please. Record sharing, I have to confess, this is not my field of expertise, but there are lots of people in the background much better than me. Through System 1, as I've mentioned, and we will be really clear that practices will be updated when people are leaving the ward. They'll be updated when people join the ward. They'll get access to the data from the 14 days as well. And I mentioned EMIS practices. And lastly, I think, leaving the ward. So actually, I feel like we've mentioned 7 days at one point, but just to clarify, it is definitely 14 days that we'll expect to virtually look after these patients. Clearly, it's personal choice. So if they don't like it, they can leave at any time. If they go into hospital, then clearly they are outside the scope of the ward, but otherwise they'll stay for 14 days, and then we'll collect the data, which we're agreeing with NHS England. We'll ask how it's been for them, how they've felt, how they've got on. We'll signpost to any support they need, so coming back to social prescribing. And I know there'll be some of you out there chuckling. We will arrange the return of the oximeter. So either by having it dropped back from where they got it, or by sending perhaps a volunteer or a member of the team out to get our oximeters back. So that, as I say, was a whistle-stop tour. I shall hand you over to Tony for the evaluation part.
These hospitals, and I also have a role at the academic health science.
Tony, you need to hold your microphone a bit closer to you.
Yeah, for some reason it struggles with this. Is that any better?
Yes, it's a little bit better.
Okay, so as I say, I have a role at South Tees Hospitals and a role at the Academic Health Science Network. So as has been pointed out already, evaluation is a key part of the project. It is a novel approach. There are two other pilot sites, one in Slough and one in Hillingdon in London. NHS England, Digital, NHSX, all really interested to try and make sure the data is comparable. So we will have a consistent data set coming from all the pilot sites to give us enough power to tell what's going on. It's going to be key for the decision that they'll take supposedly in September about whether all parts of the country will be encouraged, stroke instructed to set up virtual wards of this kind. We'll be getting data from patients, see what their experiences are, from the app itself, and then also looking at all the hospital data around admission, who's there, what level of care they get, and so forth. It may be possible to include some of the GP data as well. That's being debated. Next slide, please. So we don't actually know the exact detail of the data set yet, but it's fairly obvious that we're going to look at how many people go on the ward, how many people are escalated, how many leave, what kind of escalation they need. Do they just go in for a short stay in hospital? Do they end up in critical care? That sort of thing. Why people leave the ward early if they do. And there will be some sort of estimation of costs and how much staffing is required to set it up, and so that the NHS has a feel for how difficult this is to do. Next slide, please. There will be some sort of patient experience. We definitely want to do it as a pilot site, so we've got ongoing feedback as we go along, but there'll probably be more formal evaluation led by the Imperial team, which is headed by Aradazi, which gives you a feel for how high profile this is going to be for us. So they'll probably have some sort of exit survey and probably some sort of qualitative interviewing, which may come sometime after they've been discharged. Next slide, please. We obviously also need to know what it's like for clinicians, including the GPs whose patients are in the ward, obviously the COVID team itself, what the hospital clinicians feel. It's likely that that will be an online questionnaire and probably, again, targeted interviewing, possibly later on, so not necessarily in these first few phases. Next slide, please. So the idea is that we've got an opportunity this summer, while numbers of cases are low, to get ourselves ready for what could be a really complicated autumn and winter, where we've got lots of other viruses around that might make us wonder about whether a patient is really sick and needs COVID-style support. It's also a system that shouldn't leave any patient behind, and it's going across the CCG footprint, and we're testing the model at scale. I've got a terrible feeling I've actually stolen somebody's last slide.
You probably have, but you're doing a fine job.
Thank you, Simon. Yeah, I think that's a pretty good summary. I'll hand back to you, Simon. Are you doing the last slide?
Yeah, I'm going to do the last slide and lead into the Q&A. So next slide, please. Yeah, as Tony said, this is a big challenge. We're facing a big challenge this winter. the report that came out earlier this week thinks that January is going to be an interesting time, but we already know that places like Leicester and now Darwin are already having interesting times. So we felt that getting started on this now was a really good thing. We know that accessibility is going to be a challenge for some patients, and it's one that we're used to trying to meet on Teesside, and we're really going to do our best with this. Everyone said that we're delivering this at speed, and it has changed several times in the last few weeks, which makes it more complicated. But I'm really impressed by how everybody in both primary and secondary care right across the Tees Valley that has put a lot of effort into getting to where we are today, where we're launching this. So the next bit is the bit where all of you get to participate, and I'm really grateful to so many people giving up best part of an hour on a Thursday evening to come and listen to this, and I'd really like to have some of your questions. So if you can put those in the chat. I'm going to kick off with a couple of questions that were raised by Elm and Jan last night when she was watching a draft of this. And the first one was, so what about children? I'm going to ask the panel to take themselves off mute. And so who wants to answer about why we've not included children on the ward? Janet?
Yeah, I mean, I can certainly come in and answer that, Simon, thank you. We know that children respond differently to COVID compared to adults, and the incidence of children who become seriously unwell is much lower in the child population. We know that they don't spread it in the way that they do with other viruses, and it behaves in a different way to how other respiratory viruses often are spread and children respond to. We also know that the pilot in Hillingdon actually did open their pilot to children as young as 12, but actually in the period that they've been operating over the last 6 weeks, they've actually only had 2 children, and they were age 16. So we know that there is not, the same requirement for children, and because we're linking with adult-based services, I have to say logistically it does make it much easier to make it for the over 18s, and I'm actually thinking based on the evidence to date, we're very happy with us doing that approach.
Okay, another question that we had was around temperature, and do we want to see why are we not using thermometers alongside the oximeters? I don't know who wants to put their hand up for that one. Claire?
Yeah, I'm here. So we talked about thermometers, but not everybody has access to them. There's obviously an additional cost implication which might be able to be swallowed within a project or a pilot. But one of the questions on the app asks about fever. And so if somebody hasn't got a thermometer, they're able to enter whether they've got high temperature or fever into the app, and that helps kind of formulate the scoring system that flags up whether they're in the green, amber or red zones. And just while we're on about the app, because we still haven't obviously got the live version running yet, but just to be clear, there is safety netting built into the app. So it's not reliant, all of this is in part telehealth, it's not relying on the clinician ringing the patient to let them know what to do. The app tells them what to do. So there's kind of that self-care element to it, and the safety netting is in there within the app. But obviously the clinical team needs to check on whether that's been actioned, especially for the red patients.
Okay, 2 questions, and I think they're about the same sort of thing from, is it Amparo? And I'm going to guess it's Mary, asking, given the current incidents, do we know how many people will be monitored at any one time? And how many people can we get onto the ward at any one time?
So do you want me to answer that as well? Because
yeah,
minimum that we have to take onto the ward is 25. That's just because of the way they kind of set it up. We don't have to have all 25 on the ward at any one time. We did speak to, so a colleague and I from the CCG spoke to a GP down in the southwest who they have been using the app since April. Actually, they adopted it really quite early in the process, and at any one time they had 30 on the ward. In contrast to that, a consultant over in Manchester who was running kind of a slightly different model. It wasn't a digital app. They were making phone calls every day, but at their kind of highest surge, they had 40 on the ward at any one time in Manchester. So it's a bit of a piece of string at this point again, because we obviously don't know about the second wave and how much, but yeah, there's capacity in the ward.
I think the other thing to say in terms of the number of people we can cope with, we have access to 2,000 oximeters. So we can probably look after quite a lot of people at any one time, which is why we've gone for an app-based system rather than simply phoning people back on a daily basis. Because as you will all now know, 2,000 phone calls do take quite a lot of time to do. So that's where we've got to with that. Rachel McMahon from the LMC asks, what happens if patients can't download the app or don't have a smartphone? I'm thinking that Fiona, you might want to have a first stab at that.
Yes, so the app will allow the people looking after and monitoring the ward to input the patient's data on their behalf. So I think the simplest way is if the patient can use the oximeter, then contact is made on the phone and the nursing team in the first instance will then put the data in. So it's still accessible even if you haven't got a smartphone.
Okay. Anybody else want to comment on that?
Yeah, just also worth adding along the same vein as to patients that might find it hard to access the app. For patients who don't have English as their first language, there will also be provisions made as to a variety of translated materials that allow them to potentially record their data manually, and how we transfer that across. The pilot in Slough, they have 26 different languages spoken, and yes, they have developed a whole raft of information that comes ready translated into different languages that can help support patients that would have otherwise great difficulty in accessing any other technology, or indeed even doing it manually. So we have the solutions that have been tried elsewhere that we will utilise to make sure that we can offer it to the largest number of patients that we're able to do so.
Question from Ayad Al-Mashari about patients who get to the end of 14 days but are still symptomatic after becoming virus-free. I think none of us expect everybody to be cured and well and perfect at the end of 14 days, but they will have passed the period where sudden and acute deterioration can reasonably be expected. I think if they are significantly unwell after 14 days, then they will need to be assessed by a clinician as to what the next steps need to be, and a degree of safety netting going on. But as far as the ward is concerned, they would almost certainly be discharged at that point, unless there was a clinical reason why we thought they should need to carry on. Okay, I'm just looking at the. So yeah, I think access issues is going to be key for a significant percentage of the people that we're looking at, and I think we've already covered that the fact that that's something we're going to be looking at fairly strongly. Do
you want me to pick up Hassan's question, Simon?
Go on.
Hello, Hassan. Long time no see. Yeah. The GP involvement will be the GPs working in the various COVID clinics. So it won't be remote access from home monitoring, for example. It won't be a part of our urgent care service. It will be from the COVID clinics, which operate Monday to Friday in Darlington and Hartlepool and Stockton, but also have some weekend provision in Middlesbrough and Redcar, so you can see how that jigsaw fits together. And then the ward will be monitored during the opening times. So, and that will be clear for patients. So it'll be nurse in the first instance with access to a GP for support and advice and discussion.
I can add to the question in regards to day 14. I agree with Simon that if they're still very symptomatic, they should have a medical review, because COVID-19 can cause aftermath kind of symptoms. Some are left with breathlessness on minimal exertion that we normally see. And that might be due to thrombotic disease in the lung, or it could be due to myocardial involvement due to the virus. So those are the things that we need to think about if the patient is still symptomatic significantly after day 14. So most definitely, if they are significantly symptomatic, then they will need a medical review. Thanks.
Another thing.
Oh, sorry.
Go on. I think one of the things that came up yesterday when we were reviewing this was where to get additional information. And Tony, I think the AHSN and the RCGP have done 3 webinars now, one looking at just COVID disease, one at COVID in care homes, and the most recent one looking at COVID in children. And we're going to put the links to that in the chat. And I think the plan is that we've got your email addresses, and if people want, we can send out copies of the presentation, or at least ways a link to the presentation when it's gone onto YouTube, and we'll link in also the AHSN webinars as well. Right. Amparo's also asked how in phase 2 do patients who've contacted clinical advice. The thought is that if you phoned 111 or ended up with a swab test, you will end up in the test and trace system, and the positives will be offered the opportunity to make contact with or be flagged to the virtual ward so that we can make contact with them and invite them to be part of this. We anticipate there to be some media interest locally about the virtual ward, and we're keen to get the message out to patients that this is something that they may want to be part of. Do we have a start date for this? We're working towards a week on Monday, when we should have staff who have had some training. We should have apps, and we already have a proportion of the oximeters. I'm going to say that we're nearly at the end of the allotted time. I'm going to say thank you very much to our presenters, but most of all, thank you to you for taking part. We hope this has been a useful webinar for you to be part of, and that any comments you have about it or the way it's been run would be most appreciated, because I think we'll probably have to do things like this again over the next few weeks and months. Many thanks to everyone.